Hello everyone. I'm really delighted to be here and share with you an overview on FHIR. I think you're going to find this very interesting because a lot has changed over the last year. And I want to bring you up to speed with all these exciting new developments with FHIR. I think it's going to lead to a whole new wave of healthcare applications. My name is Patrick Jameson. I'm the product manager for IRIS for Health. I've been involved in medical informatics for a long time. And I could tell you, based on my experience, this is a most exciting time to be in healthcare IT development. And FHIR is part of the reason for this. Yes, it's a technical standard, but it's also the key driver for greater information sharing. And I think you're going to appreciate that by the end of this talk. So here's my brief agenda. We're going to talk a little bit about why FHIR is important in healthcare and what is driving the openness that FHIR is going to allow us to have. It's based on this CMS final rule. We'll talk a little bit about new kinds of applications that are coming with FHIR. So at the end of this, you'll understand a little bit about how FHIR is transforming healthcare IT. You'll stay current with what's going on with government mandates and some of the new requirements that are coming for health IT providers. And you'll know what you need to know next, what is coming and how can I respond in building these great new applications. So what is FHIR and why is everybody so excited about it? Well, it was first published as a draft in 2014. Now, for those of you who haven't been involved in healthcare IT standards, you would know, for those that have been involved, you'll know that this is a relatively short amount of time for a standard. But in this short amount of time, it has really gotten worldwide attention. The last standard, HL7v2, is really about 45 years old, and it was really designed principally to connect IT systems within the hospital. What today's market demands and what it really wants is the ability to exchange data across the healthcare, not only the healthcare enterprise, but the regions and the countries, so that we could basically get data on demand no matter where that data resides. So if I'm a patient, I want to get data on my mobile phone. I want to be able to access my healthcare record from anywhere. And FHIR really is designed to enable that. So here was just some of the motivations for the creation of the FHIR standard. Healthcare providers increasingly recognize that the lack of data exchange is leading to poor patient care, poor outcomes, and higher cost, and that we needed to do more in sharing data with different providers in the system and different components of the system. There were true barriers to patient access of health information. Yes, technically the patient owned his or her information, but try getting that information. You might have to fill out a form and maybe you might get back a fax of your healthcare data. So, to say the least, data did not flow seamlessly from different parts of the healthcare system, from payers to providers to patients. The care wasn't really as coordinated as we want it to be, as healthcare providers insisted. Additionally, healthcare is fairly opaque. We couldn't understand or couldn't access claims data. It was hard for a provider to see a patient's claims and where he might have gotten care from other parts of the system. patients found it hard to know what providers were in their network. And they couldn't really easily shop around for health plan benefits. For example, they might be on a group of medications. It would be very hard for them to price that out from one health plan to the next. So they couldn't really do any shopping based on the health plan's formulary. FHIR really opens up the ability to do much better health information sharing. It is an improved technical standard, and it's based on modern web standards using JSON and RESTful APIs. It has integrated transport and security mechanisms, but most importantly, unlike HL7v2, it defines better semantic interoperability. For example, it includes various code sets and value sets that make data normalization easier. Now, some data normalization issues still remain, but FHIR is much closer to being a true interoperable standard. What's really propelled FHIR in the last year is the ONC and CMS final rules. The ONC stands for the Office of National Coordinator. CMS is the Center for Medicare and Medicaid Services. What this final rule did is it gelled certain aspects of the 21st Century Cures Act, which was a public law adopted several years ago. Basically, what it does is it says that starting with May of 2020, information blocking is no longer allowed, and that health IT developers must be certified based on the FHIR standard, that they must comply with this standard. So this final rule essentially establishes a timeline for basically exchanging data with FHIR across the health care system. So who is affected by this? Just about everyone in the healthcare marketplace is affected, but specifically the law singles out Medicare Advantage, Medicaid, Children's Health Insurance Program participants, and qualified health plans on the federal exchange. So what must be done? Well, there must be an exchange of things like admission, transfer, discharge notifications. We must provide, these entities must provide access to their patient data through an API, and that API is based on FHIR. There also is a need to provide a provider directory API for health plans and access, if the health plan collects this, to the formulary. So what is involved in the Patient Access API? Well, this enables patients to get claims and encounter data through the third-party application of their choice. What I want to emphasize here is that this is not just about allowing patients to access some of the clinical data they may have through a patient portal. Many hospitals already provide this type of access, but this is no longer sufficient. Patients have the option of using the third-party application of their choice to get access to their healthcare data. What this means to healthcare developers is that any kind of novel, innovative, or useful application that the patient wants to engage with to get their health data, providers must allow. And so they must make available a well-defined subset of clinical information called the US CDI that contains most of what patients would like to know about their own patient care. Also, what's required is that entities are now required, health plans that is, to make a provider directory available through a provider directory API. And there's an implementation guide for this through DaVinci that health plans must follow to make this data available through FHIR. Additionally, the formulary. This is an area that I've been working on very hard in the last several months, must be made available through the same API, FHIR API. There's a DaVinci implementation guide for this, and it promises then to make all the formulary data in a health plan easily accessible by patients so they could shop around for their care. CMS is requiring that admission, discharge, and transfer information must be allowed to be exchanged between different participants in the healthcare system so that the physician, for example, can learn easily that their patient has been admitted to the hospital, or if, for example, a patient is transferred from or moved from one payer to the other, they could get all the information about the clinical care for that patient so that they could efficiently transfer care. So what are the timelines involved in this? Well, for the Patient Access API, the deadline is January the 1st, 2020. Now, because of the COVID pandemic, enforcement will not take place for 6 months after this deadline. So we don't expect enforcement to take place until approximately July 1st of 2021. But people are preparing for this now because there's a lot to do between now and July. For payers, they must make this data also accessible by January, and payer-to-payer data exchange can come later, approximately 2022. Admission, discharge, and transfer event notifications must be provided by the spring of 2021. What's really key here, and what puts a lot of momentum behind this, is that information blocking is strictly prohibited. Patients have always had the access to their medical record, but not in a convenient way. Now, patients must have access to their medical record through the FHIR API, and that all third-party applications that the patients consented to using must have access to their patient data. There are limited exceptions to this that we won't cover today, but they're fairly uncommon. So what must be shared? With the publication of the final rule, providers must essentially respond to any valid request to access, exchange electronic health information based on the US CDI standard. And they must have, by 24 months after May of 2020, they must respond to really the full EHI, meaning also resources outside of the US CDI standard. So what's involved with US CDI? Here are some of the resources that I'm talking about in terms of the standard. And you could see this is a fairly broad representation of resources. Allergies, assessment and plan of treatment, care team members, clinical notes, problems, procedures, laboratory values, medications, everything related to patient demographics, patients' medical devices, vital signs. So this is a pretty complete list. It doesn't encompass all the information that might be captured in an electronic health record. But remember, this is kind of a down payment. 24 months from now, all the data that goes into that record must be accessible. In the final rule, there were many modifications made. From the proposed final rule, they only required the address. Now they require a number of additional fields, like, for example, previous addresses, phone numbers, emails, etc. Also, provenance information is important. So where did that data come from? And when was it provided? There are a number of other minor changes. For example, in substance reactions, we now have allergies and intolerances to both substances and different drug classes. So what do third parties need to do in this? What are their responsibilities? Well, they have to adhere to privacy. So they must not share the patient's private information with any other data sources or players without their specific consent. And that privacy policy has to be written in a plain language that is easy to understand. It must provide a statement of how the patient's electronic health information is used. For example, if the patient wants to share their electronic health information for research, that is certainly allowed, but they must consent to that. So the key thing here is, with express consent, the patient is allowed to share their data with any third party. And I think you'll see a number of different interesting applications of this. For example, maybe you've submitted a test to a genetic sequencing company who, with the additional data of your clinical record, may give you very specific ideas in terms of improving your health. With the Health IT Open API, we have a very competitive marketplace emerging. So the agreement to use these APIs will allow a number of new developers that have been shut out of the system because they couldn't form business partnerships with large EMR companies. So here's just a sampling of the use cases. Building the next wave of digital healthcare applications, in collecting mobile device and patient data so we could do analysis or analytics, and then sharing information widely throughout the community, for example, for health plans, or making data much easier to transmit between payers and providers for things like prior authorization. API management is something that can make this easier, and I have a whole talk devoted to this that I'd encourage you to see. This explains how you could make these FHIR APIs accessible, how you could secure and audit them and monitor them. We also have an API development portal for making it easier for people to get started with FHIR. It's a complex standard, but there are a number of tools and learning resources that we offer that I think would make it easy for you to get started in building those great apps. Here's just a sampling, an API catalog that allows you to make a number of different FHIR queries fairly easily. So what are the key takeaways here? First, Health IT is being virtually transformed by FHIR and the ONC and CMS final rules that have really created a great push to letting the patient have access to their data through an API and using third parties to aggregate or share that information with patients and other players in the healthcare system. FHIR is one component of the Health IT stack. You need a number of tools. A development platform, Iris for Health, is great for this, as well as FHIR API management. So what are your next steps? Well, I hope you'll attend the rest of the FHIR track. We have some interesting talks on FHIR search and working with FHIR profiles that I think you'll find very useful. There are a number of learning labs that you can do, and we have a FHIR Experience Lab next week that I hope you'll attend. If you have any questions, don't hesitate to reach out to either me or my colleague Craig Lee, who is an expert on FHIR. And again, I really thank you for your time and attention, and good luck with building those new FHIR apps.